Good afternoon, everyone. Thank you for joining our webinar, The Rise of Specialty Drugs in Workers' Compensation. My name is Lori Taylor, and I'm the Director of Marketing with myMatrixx. We have a pretty full session today, so I want to go ahead and jump in and get started. But first, I have a few housekeeping items for you. Today's session will last 1 hour in length. We are recording the session, and it will be available on our website very soon. Continuing education credit is available for today's live broadcast. Everyone will be receiving an email this afternoon with a link to register for continuing education credits. Please do so within 10 days of today's webinar in order to get the credit. We will be also holding questions until the end, so if you have questions throughout, please submit them in the Q&A panel down on the right side of your screen, and we'll get to as many as we can as possible. I'd like to go ahead and introduce our speakers. We have Phil Walls, Chief Clinical and Compliance Officer for myMatrixx. In his role, he oversees all aspects of myMatrixx's clinical program and the corporately owned and operated mail service pharmacy. He's a clinical pharmacist with over 35 years of experience and is a published author, frequent speaker, and regular contributor to the myMatrixx blog. He received the 2011 Dorland Health People Pharmacist Award and is a member of several industry organizations, including the American Pharmacists Association and the National Council for Prescription Drug Programs. He received his Bachelor of Science in Pharmacy from Mercer University School of Pharmacy and was awarded doctoral candidate status in pharmacology at Ohio State University. I'd also like to welcome Dr. Jennifer Dragoon. Jennifer is the Vice President and Chief Medical Officer of Comp Services and AmeriHealth Casualty. In this position, she oversees all aspects of medical care, as well as provider relations, network contracting, and bill repricing. She regularly conducts case reviews, peer-to-peer discussions, and directs clinical programs. She also has held various positions with Independence Blue Cross, the corporate parent of Comp Services and AmeriHealth, and most recently is a member of the Medical Policy Committee. Dr. Dragoon began her career as a practicing family physician and a consultant for Chestnut Hill Healthcare. She received her BA from Cornell University in mathematics and her medical degree from Jefferson Medical College. So with that, we're going to go ahead and get started, and I'd like to turn things over to Phil.
Thank you, Lori. The agenda is on the screen now, and I'm not going to read this to the audience, but while this is on the screen, let me give you a little background on the topic of specialty drugs. My clinical pharmacists have been working on this topic for actually a series of months now and doing the research. I decided to first start talking to the press back in December. I was interviewed by a reporter, and she asked me, what are some of the things that workers' comp should be concerned about? And I decided to go ahead and throw out the topic of specialty drugs, to which the reporter responded, what is that? Are those compounds? Well, so right from the start, I want to point out specialty drugs are not compounds. They are distinctly different, and we're going to get into the definition of specialty drugs here very soon. But the fact that the reporter was not aware was a good indication to me that we had a topic here that definitely needs to be pointed out to the workers' compensation community. The next time I talked about it publicly was when I was visiting Comp Services in Pennsylvania. When I mentioned the topic to Dr. Dragoon, she immediately became very excited and told me that specialty drugs was a topic that was near and dear to her. And she went on to add some information that we had not looked at very carefully up until that point. And basically the way she put it, one of the things that keeps her awake at night are the cancer presumption laws. Because of that comment, we have included an entire section on cancer presumption in our webinar today. Now, with that said, specialty drugs is a huge topic. There are a few categories that we are not covering today. For example, there are drugs related to inhalation therapy that could be related to a workers' compensation case. There's also drugs that prevent transplant rejection. Those would also fall into this category. But the topic became so broad that we had to limit it. So what we're looking at today primarily are those drugs that our clients are seeing in workers' compensation. Could leave an opportunity for a follow-up webinar on the other categories in the future. Now, the real question probably should be not so much what are specialty drugs, but why should you be concerned? Well, the number one reason is that over the next few years, by 2018, specialty drug costs are going to rise to 50% of the total drug spend in the United States. This is a result of increased utilization and development. We have seen this market of specialty drugs grow from only about 10 agents 20 years ago to over 300 now. And we also know that 40% of the current drugs in the pipeline all fall into this category of specialty. So as we look at this, the FDA in 2012 approved what was considered a record number of new drugs. They approved 39 new agents that year, 25 of which were all considered specialty. So as this category grows to approach 50% of the entire drug spend, it is going to become a very important component in workers' compensation. In terms of what specialty drugs are, in general, specialty drugs are defined as a very expensive drug used to treat a relatively rare condition. To put a little more definition around that, let's think of specialty drugs as costing more than $600 per month. They're used to treat, as I said, a rare condition, or maybe they require some type of special handling due to dangers associated with the drug. They may require a restricted distribution network, the purpose for that being that to make sure that the individuals involved in the distribution of these drugs are specially trained in their handling. And then lastly, and possibly most important, requiring some type of ongoing clinical assessment. This is very important, and we will touch on this again as we close out the session today. But if you're going to be spending these kinds of dollars on your injured workers, you want to make sure, basically, that you're getting what you pay for. Any non-compliance with these drugs can really decrease their effectiveness, which is going to have a very negative outcome. So that ongoing clinical assessment is a huge factor. Now, we've defined them, but I want you to understand that that definition is not something that is formal. It is not coming from the Food and Drug Administration, the FDA, and different health plans in the group health care market, or even different PBMs in the workers' compensation market, can have different definitions for these drugs. So please keep that in mind, but this is just sort of a general guideline. Now, why are they so expensive? Okay. Well, one, they're very expensive to develop. This is a new market for the pharmaceutical industry. This is a departure from what we've seen in the past, and in some ways, it could be the old saying of be careful what you wish for. The pharmaceutical industry, otherwise known as Big Pharma, has been under criticism for years. Some of that has actually come from myself because we weren't seeing true innovation. People have been complaining that they're simply after profits, they're not developing innovative therapies. Well, the specialty drug market does represent innovation. They are delivering cures for things that a few years ago we did not necessarily think were curable. And they're going after rare conditions rather than focusing on the huge markets such as Lipitor experience with cholesterol lowering. Some of these conditions include things such as multiple sclerosis, hemophilia, hepatitis, HIV. So this is a very restricted market. Anytime a market is restricted, I think it's only fair to think that prices are going to be high. Jennifer, did you have any comments on that?
I did. These drugs are often used for rare conditions, so frequently there are no other options. So when you have no other drug alternatives, that allows for higher pricing potentially when there's really only one option in the marketplace.
Very good. Now, in terms of workers' compensation, where are we really going to be seeing this? Well, the first question is, can the condition arise from a work injury? Well, HIV, hepatitis C, both can be contracted from occupational exposure. On the other hand, a condition like hemophilia is inherited. So the agents, the specialty drugs being used to treat hemophilia, I would imagine will never be considered compensable. Rheumatoid arthritis. Now that's a very interesting one. That is brought about by a genetic predisposition, and yet at the same time, it can be impacted by an occupational injury, and on the other hand, an occupational injury can make it worse. So we do see rheumatoid arthritis treatment often being considered compensable. Same with osteoarthritis. That situation, heavy labor can predispose certain joints to the development of osteoarthritis, and so very often its treatment is considered to be compensable. Traumatic brain injury, spinal cord injury, catastrophic cases, the sequela of events that follow these injuries can definitely result in situations that are going to require treatment with specialty drugs, and we're going to look at those, most notably Botox. We're all familiar with Botox being used to treat wrinkles. Well, it has a whole host of indications that it's used for, many of which are going to be considered compensable. And then lastly, as I mentioned earlier, if you have employees in states with cancer presumption laws, you may be just like Dr. Dragoon and finding that this is going to be something to keep you awake at night. So looking at this, the answer is yes, there is definitely exposure to the cost of these drugs in workers' compensation. The HIV and hepatitis C, if you're insuring healthcare workers, the risk of a needle prick injury is definitely going to be of concern to you, whereas other injuries that are clearly inherited, not so much, in fact, not at all. So the population's at risk. So if I were a payer and I was trying to assess my exposure to specialty drugs, I'd be looking at who it might be. Well, the population is going to be quite large because first and foremost, any patient having orthopedic surgery is going to undergo restricted mobility following that surgery. That is going to set them up for a condition that is treated by specialty drugs. Any exposure to needle stick injuries is a population that's going to be candidates for specialty drugs. Patients with rheumatoid arthritis, ankylosing spondylitis, very likely treated with these type drugs. Patients with osteoarthritis going to have exacerbated pain, they will definitely be candidates. Just like HIV, hepatitis C can be exposed through blood or other infectious fluids. Traumatic brain injury or spinal cord injury can result in cervical dystonia or bladder dysfunction, both of which can be treated by Botox that I mentioned earlier. And then patients that develop cancer in a state with cancer presumption. So all of these different populations are at risk, and the top 7 categories that we're seeing in our data that our payers or our clients are paying for is number 1, anticoagulants, number 2, antiretrovirals that are used for HIV, then biologic and immunologic agents that are used for rheumatoid arthritis, high hyaluronic acid derivatives that are used for osteoarthritis, Botox, which we will cover in detail, used for a number of different conditions, the new hepatitis C agents, and finally cancer chemotherapy. So now backing up to the anticoagulants, First of all, these drugs are crucial for treatment of patients following orthopedic surgery in order to prevent deep vein thrombosis. The incidence of deep vein thrombosis, or DVT, is about 40 to 60%, and the AHRQ highly recommends that these agents be used to prevent this. Unfortunately, we know that only about 2/3 to 3/4 of patients that should be treated proactively actually receive treatment. Most do not. The agents that you're going to come across, and I know many of you have already seen that are being used for this purpose, are Lovenox, Fragmin, and Arixtra, and we'll get into the details on how these are used. The standard duration of treatment is typically about 1 to 2 weeks, although it may be extended up to 4 weeks in certain situations. Now, this length of time is crucial. We've talked about the expense of these drugs, but remember, for most of them, the length of time is limited. So with anticoagulants, we're typically looking at no more than about 4 weeks. As we discussed, the major use is to prevent DVT. The agents are listed there. The first two, Lovenox or Fragmin, are what are known as low molecular weight heparins. Now, it's important that you be aware of this because the third one, Arixtra, is not a heparin product. There are patients that cannot take heparin. It causes something called heparin-induced thrombocytopenia, or HID. It's an effect on the patient's blood level of platelets and can actually cause more blood clotting. So for patients with that condition, they have to avoid the first two drugs and they must be placed on Arixtra. But again, duration of therapy is only about 2 weeks. Now, in terms of cost, Lovenox is definitely the most popular. It's the one that we see most often in this category, and it's available generically. The irony is, though, is typically with a generic drug, you're expecting that to be the least expensive. But in this case, it's not. Fragmin, which does not have a generic available yet, is the least expensive in this category. So it's an unusual situation where a brand name drug might actually be the most cost-effective. And then Arixtra is the most expensive, but it really should only be reserved for those cases where you cannot use either of the first two. Again, Lovenox being the most common. Now, the antiretrovirals. These are prevention of HIV transmission and infection, which can occur from a needle stick injury, mucous membrane contact, or even contact with non-intact skin, such as from an abrasion or something of that nature. The risk of transmission looks relatively low, unless you're the involved employee. That is 0.3% following percutaneous exposure and 0.09% following mucous membrane exposure. In order to prevent the development of HID, a minimum of 2 drugs is required, and depending on the severity, there are situations where 3 or more drugs may be a factor. Now, the standard duration of treatment here is 4 weeks, although there are situations where if a patient actually develops HIV, then you may be looking at lifetime therapy. So in order to prevent this early treatment is crucial. Now, immediately following exposure, this is a period known as post-exposure prophylaxis, PEP or PEP. This is a very critical period, and this is the type of situation where if you have employees or workers that you know have the risk of this type of exposure, you definitely want to talk with your PBM in advance to set up a formulary that will kick in immediately when these patients show up at the pharmacy. You do not want to delay the start of therapy. Now, some of the first drugs that are being used are Truvada, Combivir, and then possibly Coletra. Truvada and Combivir being the most common. Truvada is a combination of 2 drugs. There is no generic available today, but the patent is set to expire in July of 2017. So we have a few more years before the possibility of this drug going generic. A 4-week course of therapy for this drug costs almost $1,400. Now, Combivir is another 2-drug combination product that's already available in generic. So the AWP is typically much less. However, it's taken twice a day versus once a day for the Truvada, so it's not half as expensive, but it runs about $819 for a 4-week course of therapy. So about 40% savings. Unfortunately, many people prefer the more expensive Truvada over the Combivir because of side effects associated with the Combivir. Things such as unexplained weight loss, joint pain, paresthesias, signs of developing infections can all lead to a failure in the course of therapy with Combivir. So because of that, Truvada is often preferred. Another interesting thing about Truvada is I pointed out a 4-week course of therapy, 28 days is what is recommended. However, this product is packaged in quantities of 30 tablets. Pharmacists are not allowed to break that package. So when it comes to time to approve it, please approve it for the full 30 days because that's the only way that it can be dispensed. Now, as we mentioned, 4 weeks is typically the duration of therapy. However, 17 to 47%, potential of almost half the patient, aren't able to tolerate the entire 4 weeks. So this goes back to what I had mentioned earlier about clinical monitoring of these patients. It's crucial that they stay on for the entire course of therapy. The CDC has guidelines in terms of how often to be used, and they also have guidelines as to when a basic regimen of 2 drugs is required versus an expanded regimen of 3 or more drugs. Now, Coletra is one of the drugs that is considered part of the expanded regimen. It is also a combination of 2 drugs. It would be added to one of the others. When an expanded drug regimen is required, Coletra is the most cost-effective. And like the others, it is available only as a brand name now, and that is expected to last through December 2016. A 4-week course of therapy for Coletra is going to run an additional $861. Now, when to use? If the patient has been exposed, or if the worker has been exposed to blood originating from an HIV-positive patient, if the source is unknown, or if it is not known the HIV status of the patient that the source came from. Therapy, the PEP, must be started as soon as possible. A delay of 72 hours could be too long. So the faster the better. So time is of the essence. And as I stated already, the CDC has excellent guidelines on the use and the protocols required for this. In terms of cost, basic regimen of Truvada runs around $1,500 for the 4-week course. Combivir looks less expensive at $877, but remember, Combivir has issues with the patient being able to tolerate it. One factor of which is extreme nausea. The recommended treatment, and many of you are familiar with this drug, the recommended treatment for this nausea is generic Zofran or ondansetron. Ondansetron has an outrageously high AWP, over $40 per tablet. So the addition of this drug could completely eliminate any savings from the use of generic Combivir. And the unfortunate thing is you have no way of knowing in advance which patients are going to experience this nausea and which ones aren't. If you have to go to an expanded regimen, the addition of Coletra drives the Truvada cost up to almost $2,400 and the generic Combivir to almost $2,000 for the 4-week course.
Still, just one quick note in case anyone isn't familiar with the term AWP. That stands for average wholesale price, and many states that have fee schedules benchmark off of that number as well.
Thank you so much, Jennifer. I appreciate you pointing that out. Now, the recommendations, we've already talked about the majority of these. One thing I do want to point out, though, is ultimately the choice of these drugs is up to the prescriber. And one reason for choosing one course of therapy over another may simply come from the fact that the prescriber knows what is effective in the source patient. He or she may elect to keep that same regimen for the exposed worker. Now, biologic agents. So let's talk about rheumatoid arthritis and some of the things that are going on. First of all, as I mentioned at the beginning, rheumatoid arthritis carries with it a genetic predisposition. So we're not really considering rheumatoid arthritis to be compensable. We're simply considering the aggravation or the additional pain as being the compensable component. Now, the biologic agents are really secondary to other agents. So you're going to see rheumatoid arthritis patients typically treated with traditional NSAIDs or non-steroidal anti-inflammatory drugs. When these don't work, then you're going to see as the next line something referred to as DMARDs or DMARD, disease-modifying anti-rheumatic drugs. And we'll talk about these in a moment. If the patient progresses to biologic drugs, then we're looking at one of two types, referred to as anti-TNF and non-TNF. TNF being a tumor necrosis factor, which is basically an inflammatory protein that's released in patients with rheumatoid arthritis, and it's essentially the body attacking itself. That's why rheumatoid arthritis is considered an autoimmune disease. So many of these biologic agents will actually prevent this from occurring or attempt to prevent this, with Enbrel probably being one of the more commonly seen agents in this. Now, in terms of annual cost for these drugs, again, based on AWP or average wholesale price, Enbrel is going to run around $39,000. The third one down, Cimzia, is the most expensive, running at around $86,000 per year. For the non-TNF biologics, Orencia is probably the most common, and that one runs for about $30,000 per year. So not cheap by any means. However, as I mentioned, first line, once if the NSAIDs fail, is going to be looking at a DMARD. There's a number of drugs that can be considered disease-modifying. Methotrexate probably being the most common. And methotrexate, yes, that is the same drug that we have thought of years ago as being simply a cancer chemotherapy agent, now used for rheumatoid arthritis as well as another condition. It does have the advantage of being relatively inexpensive with an AWP of around $3.56 per tablet. Now, viscosupplementation, quite a complicated way or term for describing an injection into a joint to basically increase the viscosity or the thickness of the fluid in that joint, with the theory being that this is going to lessen the pain. So the idea is to do this non-surgically, to inject something into the synovial fluid or the fluid that's in the joint, reduce the pain, improve mobility, and basically allow the patient to return to a higher level of activity. Unfortunately, there's little evidence to support the effectiveness of these products. Most of these patients will have already been on oral NSAIDs, ibuprofen, naproxen, or topical NSAIDs such as Voltaren gel. If they fail this, what's the physician's choice? Well, they can try one of these supplementing agents, or they can go to opioids. So I think if there's any possibility that these drugs are going to offer improvement and keep a patient off of opioids, it should be examined. But the results among your patients, your injured workers, is going to vary depending on the patient. Now, these are typically given 3 to 5 injections about a week apart. Jennifer, did you have any comments? Yes.
Yeah, interesting for us. These are not the most expensive specialty drugs that we encounter, but this is probably the most common specialty drug that we encounter. And we often struggle with coverage because it really is for osteoarthritis, which is a degenerative condition. And when is it work-related, when is it not? So those are the biggest questions we struggle with these medications.
Yeah, very good point. And even with that, we see a surprising number of cases where it is approved for payment. And so, as you said, may not be the most expensive per agent, but definitely is a cost driver in workers' compensation. This slide lists a number of the different agents that you're possibly going to see, with Synvisc being, in my opinion, the most common. It's also been around possibly the longest. And now with Synvisc 1, which is same drug, but it's simply given about every 6 months as opposed to every couple of weeks. So a difference in terms of the course of therapy. Now, looking at effectiveness, there is really immediately following the injection, there's no immediate pain relief. The patient has to really avoid activity for about 48 hours. They could even have some pain from the injection. Some patients have an allergic reaction, and then rarely there may be infection or bleeding associated with it. On a long-term basis, there should be, and I stress the phrase should be, less pain in the joint. It appears to have some pain-relieving properties. It may actually stimulate the body to produce more of its own hyaluronic acid, which is the viscous agent in the joint. The effect should last for several months, and it could be effective in relieving the symptoms. It's most effective if it's given early on in the course of arthritis when the symptoms are still mild to moderate. Now, let's change gears and talk about hepatitis C. This is a condition that affects, depending on the sources you look at, about 2.7 and 3.9 million people in the United States. Still considered a relatively rare condition, but at the same time, that's a large population. Interestingly, I would say I probably see more about the drugs used to treat hepatitis C in the Wall Street Journal than I do in any of the medical journals. This is simply because of the expense. This is really the drugs that are causing so much attention to be placed on specialty drugs, with one sort of leaving the pack down into the item newer entries, Sovaldi. Sovaldi first hit the market back in December. There were headlines almost immediately. New therapy cost $1,000 per day. Last week, the headlines I read involved Senator Waxman from California, and as well as others, who is asking Gilead, the manufacturer of Sovaldi, to justify the price. So again, goes back to my comments earlier. Be careful what we wish for. We've been demanding innovation from the pharmaceutical companies. They're delivering it. And this type of innovation obviously helps patients in the United States. It also helps worldwide. But one thing that is very difficult to understand is why Gilead, the manufacturer, is offering the same drug overseas for about 1% of what they're charging in the United States. So 3-month course of therapy in the United States is $90,000, whereas overseas it's $900. That's why Senator Waxman is asking the questions that he is. Now, in terms of managing exposure, again, I refer you to the CDC. They're an excellent resource. They're first going to recommend testing the source for anti-HCV, which is antibodies to hepatitis C. There's going to be baseline testing, also looking at ALT, which is alanine aminotransferase. About 2/3 of patients that are infected are going to have an elevation in this enzyme, and so on and so forth. As I said, the CDC is an excellent source on this. The risk of exposure, or the infection following a needle stick exposure, is about 1.8% if the source was positive for hepatitis C. So, significant risk. Now, in terms of drug therapy, very interesting, the first drug there, Pegasus. Pegasus is a form of interferon. Interferon is a drug that we've known about since the late 1950s. Many people consider it to be sort of the first specialty drugs. But in spite of the length of time on the market, there were many decades passed before some of its true value began to be seen. And then we did see that because of its effect on increasing the immune response, it was effective in hepatitis C, but not when given alone. It actually has to be combined with other drugs in order to truly be effective. One of the first ones that was combined with was ribavirin. If it's combined with ribavirin, the sustained virologic response, which is basically just a way of saying that the virus disappears and stays gone for 24 weeks, about a 46% success rate with this combination. So not real good, but certainly better than anything had gone before. Now, since then, what we're seeing is when it's combined with other agents, such as Victrellis and Incivic, the sustained virologic response goes up considerably to 63% and 72%, as does the cost. So now we're looking at a cost of therapy for that first combination of about $75,000 and over $100,000 when combined with Incivic. So the response is improving, but the cost is going up as well. And then when we combine it with the most recent agents, Alisio and Sovaldi, again, price continues to climb, with the combination with Alisio being over $100,000 and the Sovaldi climbing to about $112,000. But now we're up to an SBR, or basically what could be called a cure rate, of about 89%. So very, very significant improvement in outcomes, but with a corresponding cost. Now, what we know from this, the alternatives, one could possibly be a liver transplant. That's going to cost about $280,000. In the absence of that, the care of a patient that doesn't require a liver transplant, we're still looking at about $100,000 per individual. So if we look at the cost of a specialty drug managed well, in other words, the patient is compliant and doing everything that they're supposed to, and we receive an 89% cure rate, we can actually see that these drugs are cost effective, even though the price tag looks outrageous. And then there's the quality of life, which is in many regards immeasurable. It's hard to put a dollar figure on that. Now, the botulinum toxins, or Botox, numerous indications for this drug today. It's been around, or we've known of it and been aware of it since 1949. It seems a little ironic that something that can cause botulism poisoning and actually kill is now being used as a drug. But that's not unprecedented. Many drugs that are in use today all started from natural sources such as botulinum. In 1989, it was first approved for the FDA to treat blepharospasms or eyelid spasms, as well as strabismus, otherwise known as crossed eyes. Since then, it's gone on. In 2000, it was approved to treat cervical dystonia, basically reducing neck pain. 2002, approved for treating wrinkles, or otherwise known as frown lines. 2004, approved for treating underarm sweating in excessive situations. 2010, two more indications, reducing muscle stiffness in the treatment of chronic migraine. And then in 2011, approved for treating overactive bladder with neurologic conditions or spinal cord injury. So the use of this drug has expanded dramatically over the years. So now when it comes to workers' compensation, several areas where we could see it. One following spinal cord injury or traumatic brain injury causing upper limb spasticity. We can see it being used for cervical dystonia associated with trauma. And we can see it used for overactive bladder associated with spinal cord injury. And then we're also seeing it with chronic migraine headaches. And Jennifer, I think that might be an area that you want to comment on as well.
Yes, as we discussed, Phil, in the past, in terms of headaches, you know, migraine is a diagnosis that we question in workers' comp. It's generally not a work-related condition, although, you know, occasionally we are compelled to cover migraine-related treatment. The official disability guidelines, they benchmark the likelihood of causality for different conditions, and for migraine, the likelihood of causality due to a work condition is less than 5%. So even the science says that generally not a work-related condition, although sometimes ends up covered as a work-related condition.
Yeah, very interesting. And as with other conditions, is something that we see approved quite often. Looking at the treatment costs associated with botulinum or Botox, typically the AWP on this is about $630 for a 100-unit vial, or $1,260 for a 200-unit vial. And the frequency of injections is no sooner than every 12 weeks. So this can be an ongoing expense. It is not a cheap therapy, but at the same time, especially for some of these catastrophic cases, it can definitely improve outcomes for these injured patients. Now, with that, I'd like to turn it back over to Jennifer to talk about cancer presumption and some of the therapies being used in that regard.
Thank you, Phil. So cancer, generally we don't think of this as a work-related condition. When is cancer a work-related condition? Most commonly, when we talk about firefighters, there's some evidence and there's a number of states that have stood behind supporting the coverage of cancer as an occupational disease for firefighters. So the medical literature on this is actually pretty conflicting. There's really not been a lot of conclusive proof that cancer is more common in firefighters overall. There are certain cancers, prostate cancer being one, esophageal cancer being one, that a few studies have shown a small to moderate increase for firefighters. One that we know for sure, mesothelioma, that's caused by asbestos exposure. That one's a little more straightforward. The rest of them, though, the literature's a little murky. There's really not a lot of proof that it is caused. There's also not a lot of proof that they're safe from increased cancer risk. So there's a lot of room for interpretation on this subject. So a number of states have adopted cancer presumption laws. Basically, the premise for these is the cancer in a firefighter is assumed to be a work-related condition unless proven otherwise. So the onus becomes on the employer or the insurer to defend that case as not work-related if they believe that to be the case. You can go to the next slide. Now, of these 33 states that have enacted legislation, the conditions of their legislation are widely varied beyond the cancer presumption. So here, we've outlined here some of the different terms of some of these laws. So some of them restrict certain types of cancer for coverage or non-coverage, certain occupations. So for example, EMTs in some states, first responders of other types are included in the cancer presumption. Work status, pre-employment physicals are a common condition. Typically, they require that the firefighter has had a physical before they started their position and been found free of cancer, which usually if they have cancer, they don't continue into the employment anyway. So next slide there. A couple more conditions here on slide 44, if you could forward. Thank you. One of the bigger issues is the retroactivity, and states have addressed this in different ways. So, for example, in Pennsylvania state where we're located in, the statute went in 2011. So what happens to a firefighter that was diagnosed with cancer in 2010 and has ongoing treatment, you know, to today? Are they covered? Are they not covered? Some of the states have set rules around that. Some of the states are allowing that to be driven by case law. So every state is different. Next slide there. I've just included, I've included some dollar figures here for lung cancer. Now, lung cancer, as I mentioned earlier, there's not conclusive proof that it is or is not caused by firefighters' occupational exposures. But being one of the most common cancers in the United States, this is one that comes up relatively often, and it frequently is covered under these cancer presumption laws. So this is a small sampling of potential drugs. The vast array of combinations and cycles that can be utilized for chemo is ever expanding, and often very expensive. So frequently, patients will unfortunately have to go through multiple rounds of chemo over the course of their disease. And as you can see, the cost can be pretty significant. The next slide here, the malignant mesothelioma, that's due to the asbestos inhalation. That's a very direct cause, frequently compensable under workers' comp when you can define that there's been an asbestos exposure. And here's some of the treatments that can be utilized for that. So just a little summary on noncompliance Phil mentioned earlier, particularly when talking about hepatitis C. Although these drugs are very expensive, often the noncompliance or not utilizing them can be even more expensive. So anticoagulants aren't used appropriately, and an injured worker develops a blood clot. That certainly has cost to the insurer and the employer, but it also adds huge quality of life effects to the injured worker themselves. The other just small point I wanted to make, these medications can be very complicated. You need to make sure that the patients do remain compliant. You manage side effects, other drug interactions. A lot of them have a number of drug interactions. And you need to ensure that the most appropriate treatment is being utilized. So it's important to have a resource for that. Certainly the PBM, your pharmacy benefits manager, is probably the biggest source you'd have, but good relationship with treating providers, home care, infusion companies, all of those can be a source of information.
Thank you very much, Jennifer. At myMatrixx, we consider the associated care that these drugs requires to be a very complex type of care. It requires PBMs, payers, all healthcare providers to start thinking about drug therapy in a different way. Traditionally, the spend associated with drugs as well as other therapies is often viewed very much with what I refer to as a silo mentality. In other words, we like to keep our data in nice, distinct buckets so we can say we're spending this much on drugs, we're spending this much on hospitals, we're spending this much on providers, etc. Well, when it comes to specialty drugs, in order to really evaluate the cost and the associated savings that these drugs can bring, it requires us to look at it in a different way, and it requires us to manage it in a different way. So all the patients that are on specialty drugs, one, should be monitored for compliance. So many drugs in workers' compensation, compliance is not an issue the way it has been in other areas. So, if you have a cardiac patient, the doctor, everyone involved understands how important it is that that patient take their blood pressure medication or whatever it happens to be. With drugs commonly used in comp, until now, there hasn't been that kind of attention on compliance. If a patient's in pain, you can pretty much rely on them to take their medication when they need to. With drugs like this, to prevent HIV, patient might need to be reminded, they need to be monitored to make sure that they're taking the drugs on schedule, that if the side effects are a problem, that the patient understands that they need to be talking to their physician as soon as possible, and not simply to give up on the medication because of those side effects. The adverse events and the side effects associated with these drugs needs to be reported, and that reporting needs to be to the physician as well as the FDA. There are prescribed forms to use by healthcare professionals to report these side effects so that they can be monitored and therapy can be improved. Physicians need to be made aware of noncompliance. It's too easy to write the prescription and assume or hope that your patient is going to follow those directions. It simply doesn't happen all too often, and that's where a clinical pharmacist can come into play to communicate with these patients. And basically, all this is to ensure that the dollars that you spend on these very expensive therapies actually pay off. The worst waste would be for you to spend a significant amount of money with the assumption that your injured worker who has experienced hepatitis C is going to be cured after 4 weeks, and then to find out that even though you paid for the drug, patient didn't take it appropriately, and that cure rate simply did not occur. So the monitoring by clinical pharmacy through your PBM is a way to ensure that basically you're getting what you pay for. Now, in terms of things that are coming up, as I said, 40% of the drugs in the pipeline all fall into this category of specialty. Many of them are for a lot of the things that we're already seeing, hepatitis C, HIV. We're also seeing agents that are going to be for bone loss disorders as well as hip fractures. Population is aging, means the workforce is aging. Conditions like this are going to become more and more prevalent, and the likelihood of compensability will continue to increase. In addition, along with that aging population, we'll be seeing many more specialty drugs for both rheumatoid as well as osteoarthritis. There are specialty drugs in development for chronic fatigue syndrome, and even more for upper limb spasticity. So one of the takeaways from this is when you think about drugs, continue in the traditional mode of thinking about your drug spend in terms of brand and generic. That will continue. I think it needs to be further subdivided into traditional, specialty, and compounding. So start thinking of your drug spend being broken out that way. This will allow you to focus on specialty. Now, the term brand and generic, and we've been using that today, does still apply to most specialty drugs. I'm sort of setting the stage here for a possible future webinar. Some of the specialty drugs, though, are not manufactured in the traditional sense. They are considered biologic agents. They are the result of recombinant DNA technologies and things of this nature. These type drugs, it is not very easy for a generic company to reproduce what a brand name company has done. So we now have a new term. And again, like I said, I'm just setting the stage. Generics for these type products will not be referred to as generics. They're going to be called biosimilars. As a result, we have a whole new set of laws being created to dictate the use of biosimilars in terms of when they can and cannot be used. Very different from generic laws that exist today. So if there are any policymakers in the audience, this is just something to be thinking about. The fee schedule that's been so nice and distinct in most states of simply brand and generic drugs is going to have to be expanded, and we're going to need to put a lot of thought into how that occurs. So in conclusion, specialty drugs are the fastest growing segment in the pharmaceutical market. They definitely are going to have an impact on workers' comp, but depending on your patient demographics, they will have more or less impact on your particular business. And then, at least as we understand it today, the injured workers most likely receiving specialty drugs are going to be first emergency responders, public safety personnel, law enforcement officers, correctional officers, healthcare workers, and then certain defined workers that are in those states that have cancer presumption. So with that, Lori, we're concluding the webinar, but if you'd like to, maybe we can open it up for a few minutes of questions.
Yes, thank you, Phil. We have been receiving some questions in, so I am going to throw some out to our speakers. One question was, Phil, what percentage do specialty drugs make up in workers' compensation?
What we're seeing in our data, the percentage as a count is very, very small. It's about 0.25% of 1%. So based on that, why is this even on the radar? Well, because we're talking about a fraction of a percent in terms of prescription count, but in terms of dollars, it represents 2% of our clients' drug spend, and it's only just started. So the ratio of spend to count is very high, higher than any other category of drugs, and this is growing from pretty much non-existent a year ago to 2% of spend today and climbing.
Okay, thank you. I'm going to throw this one out to Jennifer. What is your biggest concern with specialty drugs today?
I would say, actually, my biggest concern is what's going to be coming. So this area is absolutely exploding. So we have a good sense of what's out there today, how we manage it. But I do think over the next, few years, there's going to be more and more options treating more and more conditions, expanding indications on existing drugs. So I'm more worried about what I don't know today.
Okay. Here's another question. I'll throw it out to both of you, and whoever would like to take it first. AHRQ recommends anticoagulants, but why must we use these designer drugs when other drugs are available? And I'm not quite sure if you know what AHRQ stands for. Okay.
Yes. So, Jennifer, do you want to go first?
Go ahead.
Okay. So with this, what we know is the effectiveness of the new specialty drugs is much greater. And so it's that ability to decrease the risk of deep vein thrombosis, which is why you would want to go to these agents. They are more expensive. Keep in mind, talking about a couple of weeks of therapy in most cases, and so the expense is limited. But the cost of non-compliance, as we saw, goes up dramatically if a patient indeed were to develop DVT.
Okay. There's a question that just came in. Are most of the specialty drugs being processed through PBMs or internally dispensed by providers?
There's going to be a mix of both. So it's very important to provide copies of your paper bills to your PBM so that their clinical pharmacists get the entire picture of what's going through the office versus what's going through the retail network. Another interesting thing about specialty drugs in comp, though, is most of them do not require that restricted handling. So we're seeing these drugs going through our retail network as well as our mail service pharmacy. Walgreens and CVS probably making up the lion's share of where specialty drugs are being handled.
Okay. And a lot of it has to do with where the drugs are administered. So if they can be administered at home, often they can go through the pharmacy. If they have to be administered by a physician or in an infusion setting, then typically they go through the provider hospital outpatient setting.
Excellent point. And just continue to elaborate on this topic. As we mentioned earlier, Jennifer, Synvisc and those type drugs being probably the most prevalent specialty drugs. And of course, Synvisc is administered in the office. Some of our clients, though, in order to take advantage of the PBM savings, will actually go through our mail service pharmacy, have the prescription dispensed by us, but we dispense it directly to the physician for in-office use. So that's another avenue.
Dr. Dragoon, I'm going to address this to you as well, since this is in your area of the country. Are firefighters and first responders in Pennsylvania the only cancer presumption eligible in that state? Are you aware if there are any other occupations?
Yes, so if I recall correctly, it's pretty specific to firefighters and first responders. And I forget how they define, firefighters and first responders. There's questions about volunteer versus employed firefighters. But in general, most of these statutes are pretty specific just to that occupation.
Okay. We've had a few questions. It seems like specialty drugs and then also compounds. You mentioned this in the beginning, Phil. There's a little bit of confusion about that, but that's a hot topic. Are any compounds considered a specialty drug?
Yep. Think of your specialty drugs as coming from a traditional manufacturer, not an individual pharmacist. So, going back to that definition, if we just looked at cost, specialty drugs costing over $600 a month, that definitely would imply that compounds are, but when we look at the other areas, we're talking about drugs that have been FDA approved, they've been evaluated, they've been determined to be safe and effective when used as prescribed, so they are manufactured products, not compounds.
Okay. Another question, do you find most PBMs assisting adjusters to understand the need for specialty drugs and its use for approval? So I'm not sure, I'm just reading the question right now. I guess they're saying, do you think adjusters understand, and I think this is part of the reason we wanted to do this webinar, the use of specialty drugs and how to approve them?
Right. I don't think many people truly understand. Again, Dr. Dragoon being one of the exceptions when I was talking even to the physician community, first question I would hear is, what are specialty drugs? So the awareness is only just now starting. but this has the potential to explode in terms of cost. So that's why we wanted to, this is basically one of our first steps in making our clients aware and giving them the information they need to properly adjust and approve these drugs.
Okay. I think we have time for about one more question. Thanks for sending your questions in. We're definitely getting a lot of questions from the audience. What is the industry standard for the drug cocktail for HIV exposure? What meds and for how long?
Well, the industry standard is basically a cocktail of two drugs, Combivir and Truvada being the most common. Combivir offering a perceived benefit of being generic, Truvada being the more expensive of the two, but because Truvada is better tolerated, in the long run, it is going to be a better choice. So it's more expensive, but the outcomes are better because the patients tolerate it, and since Combivir runs the risk of adding more drugs to treat nausea and things of that nature, that generic can actually end up more expensive. So Truvada is a two-drug combination. Then if additional therapy is needed, then the next recommendation is to combine that with the combination product Coletra.
Okay, great. Thank you. I'd like to thank again Phil Walls and Dr. Jennifer Dragoon for presenting today on this really kind of hot topic that's been going on, not just in our industry, but as Phil has said, really across the market. Just a couple reminders. You will be receiving an email in just a little bit with a link to register for CE credit, so please do that within 10 days in order to get credit for participating in today's webinar. You'll also receive a survey, and we'd love to get your feedback and any recommendations or suggestions for future topics you'd like to see us cover. Again, today's session was recorded, and we'll have it available on our website this week. And we also have a white paper coming out in the next couple weeks on this very topic. Most of the information, if not more, probably is going to be in the white paper. It's a very comprehensive white paper that Phil and our clinical team has authored in addition to Dr. Dragoon. And we will be getting all of the participants today a copy of that when it becomes available via email in the next week or so. So thank you for joining us, and we look forward to having you join us next time. Thank you.